Chairman, committee, appreciate the opportunity to come share some thoughts with you with respect to rural hospitals. My name is Jimmy Lewis, CEO of HomeTown Health. We represent about 50 rural hospitals in Georgia, 15 or so in Florida, and a number of other states, including Iowa and Virginia. We're also involved in education, and we have an online education program, and we provide education to about 10,000 students over about 20 states. So we're deeply involved in that. Most of the education has to do with payment, reimbursement, and how to get paid through the complex claims process that we have to deal with. I come to speak to you today from some experience that we've had. Since May, we've made about 60 hospital visits in the state of Georgia. And in those 60 visits, we carry policymakers and legislators for the purpose of listening to what their issues are. And so I share with some of the things today that come from those visits. I want to echo much of what you've heard today, but I want to give you a different spin and to specifically answer one of the questions: is CON working? And if so, how is it working? Well, in the rural hospital community, when we talk about crisis and we talk about fragile, it's the real situation. Our definition of crisis is a rural hospital that's got 1 day's cash on a $15 million a year operation. Our definition of crisis is when we are having to work with them day to day to determine when their upper payment limit distribution will occur on the day, or to determine when their upper payment limit, if they've got a nursing home, when it will pay so that they can calculate their payroll. We have done no less than what we call payroll interventions. We've done no less than 10 of those since January, and that means that we get a call on Friday that on Tuesday we won't be able to make payroll. What do? And we have to go chase the means to find cash to do that. So our rural hospitals are truly in a very fragile situation. We have closed 5. We currently have another 20 that are very fragile, but inside of that 20 we have some that are really fragile in that they have had their sustainability cost shifted to the county government. And that cost shift to the county government is a very detrimental position to be in. Now, to address that properly, I want to share with you how we got there, because I think you'll find it most intriguing as we talk about cost or cross-subsidization and how we move dollars from point A to point B. Go back to about 1999. In 1999, there was a decision by the state in an economic downturn to drop the payment on Medicaid to about 85.6% of cost. That was a cost shift, and that cost shift was made from state government over into that sustainability payer mix matrix, and the cost shift was made to commercial payers. On the payer mix, you have Medicare, Medicaid, self-pay, commercial, and then other assorted. And at the time the decision was made to cost shift from state government over to commercial because the commercials were paying substantially above cost. They did that in an effort to handle that particular problem, and it seemed to work okay there. So from 1999 until about now, you heard earlier this morning that there was $1 billion cost reduction that's occurring out of the Affordable Care Act. I would submit to you that there's that $1 billion reduction that is occurring, but there has been another $1.3 billion that has occurred since 1999 that is a product of the conversion to CMOs, the product of a conversion to a number of different algorithms by the state in order to save money. We have in Georgia incurred and are incurring about $2.3 billion of cuts to the Medicaid system. You say, well, how can that be? Well, it's evidenced by the fact that in the Medicaid program and in the state health program, we are one of, if not the lowest paying Medicaid state in the nation. And then on a per capita basis, we're one of the lowest paying per capita Medicaid states. So the question is then, where do we go from here, and how do we get there? And I would submit to you that one of the ways we get to wherever we're going is we have to have CON for a very, very unusual reason, and it is this. In our rural hospitals, there have been basically 3 service lines that have been carrying us. And those 3 service lines, as you've heard some today, we have some surgery, we have some imaging, and we have some labs. And in the last year, we've taken $300 million of labs out, so that's basically decimated that service line. We have imaging and we have surgery, and those imaging and surgery, the comment was made earlier today, we have protected revenue streams. And the answer is yes, we have had protected revenue streams in that cross-subsidization of the state and such, that is carrying 2 revenue streams because it has kept the commercial side paying higher than it otherwise would have paid. And in rural hospitals, we have approximately 20 of those hospitals, and this is evidenced by the fact of what we've seen on the Rural Hospital Stabilization Committee. I serve on that committee, and we've seen it over again in the hub and spoke. The hub hospitals are being carried right now by the fact that the surgery that is there and the imaging that is there are the only two things carrying those hospitals. It was the third as long as we had labs, but we no longer have labs. Those have gone to LabCorp. So I would submit to you that CON has protected the surgery and imaging in those communities. Again, there are approximately 20 of them. It has protected that revenue stream to prevent outsiders coming in from taking over the revenue streams or joint venturing those. And it can be said, well, there's not enough population there to do that. There is enough population to either do a 1 day or 2 day or a 3 day a week to pull some of that revenue out, and that revenue loss will go straight to the detriment of that hospital. What we've seen is on the other 20 or 30 that are not in the situation of having the surgery or the imaging to carry them, what we've seen is we've already seen that there is a direct cross-subsidization and shift over to county governments. And county governments, I can give you a hospital right now that's a very small critical access hospital that's got $8 million debt to the county. It'll never pay it. I can give you another one that's got $19 million, another one that's got $9 million, but one that's classic above all is last year in Habersham. That Habersham hospital, we come to learn, had a problem because of this sustainability of paramedics, and the county had to absorb $40 million in hospital debt in order to keep that hospital viable in the community and to protect the county's investment in it. We learned out of that while we want to know if CON is working. CON is working to preserve the revenue streams in those hospitals. But CON is also working to preserve the bond capacity of rural counties. And nobody ever thought that there was a link between CON and a bond capacity. I can tell you that the number of times we've had to go into hospitals and help that hospital convince either the county or their bond lawyers that there is a link between maintaining that CON in that community and keeping that bond covenant not in violation. It's extremely important for us to do that. We've been able to do that.
Let me interrupt you because this is good stuff. There was a presentation